Perfect. All right. So clearly, they saved the best for last. I think this is the last talk, and this is about hip fractures, and it's a bread and butter kind of fracture. So hopefully, most of you have a good basis, and this would be a short review highlighting some of the salient points. The picture, by the way, is not to suggest that you should ignore anything about hip fractures. It's just to emphasize the fact that we will not be talking about the head of the femur. And like I said, if you are in a quiet environment, unlike Tony's, feel free to unmute yourself and ask questions during the talk, or just respond in some way. All right, so let's get going. All right, so full disclosure, I am a part of a senior member in the OTA classification committee, and therefore I will be shamelessly promoting the AO OTA classification during this talk. Mainly because I think it's very important to understanding how to manage these fractures, and hopefully I will convince you why. However, if you do have any questions about the classification or complaints about this excessive use of classification, please see this guy who is in charge of the 2018 update of the AO-OTA classification. So everything, all questions classification-wise, after this talk can go to him. All right, so let's go to our objectives. So the objectives of this talk would be after this talk, you should be able to classify all types of hip fractures, to identify the key management decisions, and to describe the treatment for these fractures. We're going to start with the femoral neck fractures, or the intercapsular hip fractures. And you'll see it's a little bit going the opposite direction of the AO-OTA classification, because in the AO-OTA classification, the A's are the extracapsular in the case of the extra-articular, and the B's are the partial or intracapsular as far as hip fractures, and the C's are going to be your head fractures. So we're going to go a little bit backwards. So we're starting with the B-type fractures. And one of the nice things that Meinberg and company did with the new update of the classification is that they incorporated a lot of previous classifications into the AO-OTA classification. So eventually you will just have to know just one classifications for fractures. So for the femoral neck fractures, these are the 31, so it's the bone 3 and 1 proximal, so bone 31, B-type, which is femoral neck, and you have your B1s, which are the old people fracture, or the subcapital fracture just below the head. And you can see how they incorporated the Garden classification. Let me move this thing here. Into the AO classification. So you have your point 1s, which are the Garden type 1 or valgus impacted fractures, the point 2s, which are the non-displaced one or the Garden 2, and the point 3, which is the displaced fractures, Garden 3 or 4. So these are the old people fractures, and the young people fractures, which are called trans-cervical or in the mid-neck portion. They incorporated the Paul's classification into it. So you have a simple, they're basically divided into the point 1s, which is a simple fracture pattern, point 2 is a comminuted one, and the point 3s, which are shear. But you can add to each type the Paul's classification, which is the direction of the main fracture line, depending on how horizontal it is. So Paul 1 would be horizontal, Paul 2 would be 30 to 7 degrees, and Paul 3 vertical. And then you have your B3s, which are the basis cervical fractures, which you, as you will see, are not exactly treated like neck fractures. They're more like trochanteric fractures. They get treated. So, and another thing, but you know, since they did add them to the adding to the classification of neck fractures, there is obvious, there's two fracture types that they missed. Since what makes a basic cervical fracture is the fact that you have both the greater trochanter and the lesser trochanter intact. But as you will be seeing more and more hip fractures, you'll find that there are some cases where you have just the lesser troch intact, and sometimes you have just the greater troch intact, and the rest, and the other thing is, and the rest of the neck is broken. So there's two fracture types at least they didn't account for, and it's interesting because they have room here in the page, and I'm definitely gonna push Meinberg and the committee that I'm part of to work on filling this page. So there's some missing fracture types. Okay, anyway, so one thing we're gonna try to do is to get you guys more engaged, is to ask some polling questions. This is very high level Zooming for me. So I'm gonna launch this poll, and the question is, before I launch the poll, is how would you classify this, this fracture, okay? Is it a 31B or femoral neck, type 1, type 2, or type 3? So you have 30 seconds to engage with this question. I need more participation. More, you got 8 people of 17. That's 52%. I can see everything. You have no choice. Okay, 10 of 17. Okay, that's it. I'm going to end the poll. I'm going to share the results. All right, so this is what we got. So we have a nice distribution. And this, so I'll get rid of this thing. And the answer is, it's a B2, right? So the ones are going to be the old people fractures, and they're going to be the one that's just subcapital. Subcapitals, whenever you see the physis here, it's going to be just below that, or just below the neck. And when you see a fracture right through the neck, really resembling what you see in this picture, the B2.3 fracture. So you have it through it starts maybe close to the head, but ends with a nice neck piece. So this is exactly the 31B2.3 or the 0.3 fractures. And you can see you can add the Powell's classification as a parenthesis in case they decided to call it an R. So it's a very vertical shear type fracture. So that's that would be the correct. So let's talk epidemiology. And this is just from ortho bullets. You got women more than men, you got whites more than blacks. It turns out that the United States, like in Corona, is a leader in the world, the highest hip fracture rates worldwide. And it's the most expensive fracture to treat per person basis. And I like this graph because we normally attribute the fact that it happens in an older age to osteoporosis, but you can see that here, this is the degree of your osteoporosis in the femoral neck, bone mineral density. But you see that although you get an increase in the incidence of fractures with poor bone mineral density, age itself also has a separate effect, meaning that you also need a reason to fall. It's not enough to be osteoporotic. You need a reason to fall. And that increases with age and your comorbidities. So I like this graph. Something weird has happened with 50 years. Everybody behaves pretty much the same, but 50 years old, I don't know what's going on with 50 years old, but the men, usually it's women more than men, and pretty much the same kind of pattern, but in 50-year-old men outnumber women, osteoporosis at the age of 50, I guess, are way outnumber women in hip fracture incidents. So this is just a call to you residents to make sure that your attendings take their calcium pills because something's happening in this age group. Okay, let's, another question, engagement. So your patient is a 67-year-old male. He asks you about his chances to die in the next year. Your answer is gonna be less than 10%, 10 to 20%, 20 to 30% or 30 to 40%. And I am going to launch another poll. Stop sharing. Let's see. So, all right. So launch poll. Okay. So answer, this is the same patient you saw, the vertical shear fracture, but he's 67. And he's asking you, you know, am I going to die next year? Guiding at 40%, 64, 70% engagement. Oh my God. So it's all over the place. So you have 10 or 20. Okay, let's see let's end the poll. 82% engagement, 30 seconds. Nice. All right, so share the results. So most people think it's going to be 20 to 30%. And let's see the results. Turns out it's actually 30 to 40%. Unbelievable. And this is based on a study, on a JAMA study, and you heard Dr. Ding about how important JAMA studies are. I'm going to find this. So it's a JAMA study from 2009, and it's a big survey in US. In the US, you got 20 years from 20% of Medicare claims, 800,000 patients. I don't think a bigger study has been done. Age above 65, and you can see men more than women die. Women have it more, but men tend to die more. And it's between the 30 and 40%. And it's across 20 years, hasn't changed much. Although we don't have the continuation study for this, but this is a pretty constant number, 30 to 40%. Oh my God. All right, decision making. So this is from on the left side, you'll see an algorithm from the OTI decision-making book. This algorithm happened to be written by Eric Meinberg. But you can summarize this whole algorithm in terms of key decisions to be made for femoral neck fractures into two questions: whether your patient is young or old, and whether the fracture is displaced or non-displaced. If your patient is, if the fracture is non-displaced, doesn't matter what age he is, he's going to get a percutaneous pinning. We call it closed reduction and percutaneous pinning, but that always bothered me since we're not doing any reduction, right? But it's still, it's just percutaneous pinning. So this is treatment for any valgus impacted or non-displaced fracture. For displaced fractures, if you're young, you're going to get ORIF or a closed reduction percutaneous pinning. And if you're old, you're going to get a hemi or a total hip replacement. So what are the controversies that we have in treatment? One is if the fracture is displaced, should we do an open or closed reduction? And if we do, once we do this reduction, should we use a sliding hip screw and plate construct or just screws? Other controversy is if we're going for arthroplasty, should we do a total hip or a hemi? And finally, if we're doing a hemi, should it be cemented or non-cemented? So hopefully I can show you some data that you can hang your hat on to answer this question. So your patient tells you now, this is the same vertical shear patient, it tells you now that he's actually 47 years old. And you therefore recommend the open reduction internal fixation. Your choice of an open reduction will increase your patient's what? His risk of non-union, your accuracy of reduction, his risk of infection, or his risk of avascular necrosis. And I am going to launch a poll while you're thinking about this. Wait a minute, poll. I'm gonna get better at this by the time this talk ends. All right, 30 seconds. Hit me with your knowledge. All right, you got 29% engagement. 35, 41, 52, nice. And the results are in, share results. All right, so most of you think it will increase the accuracy of reduction. And the answer is, it's actually going to increase your risk of non-union. So this is based on a great study that was done by no other than our Joseph Patterson and some more shed, and you have Miklau somewhere in there. But this is a study that was published in JOT of this year. And it's a great study. It's basically, they took all of the, it's a retrospective study, but they took all of the leading trauma centers. All of these are big names in orthopedic trauma. And they retrospectively looked at the open versus closed reduction. So you have some centers doing all patients open, some of them doing all patients closed, some have a mix. They did some, all the statistical wizardry and propensity scoring and what have you to try to make it as robust as possible. But the results were that the only thing that was different was that open reduction had more non-union. They didn't see a difference in infection rate. They didn't even see a difference in the accuracy of reduction. They actually had an independent observers look at the reductions, and they found an equal level of anatomic reductions between the closed and the open. And like I said, they try to control for all of the other parameters. But an important study that has changed many traumatologists' opinion about whether they're going to open these fractures or not. So what about using a sliding, once you did a reduction, open or closed, should you use a plate and sliding hip screw, like a DHA that we use here, or just the cannulated screws? So for this, you have a nice study. It was published in 2017 in The Lancet. 1,000 patients, this time it's a randomized control trial, prospective, and they compared these two implant options for femoral neck fractures. And what they found that if you have patients that are smokers or have a displaced or base of neck fracture, specifically the base of neck fractures, they tend to do better with a plate and a sliding hip screw construct, which is a fixed angle compared to the cannulated screws. All right, moving on. Well, it turns out your patient lied, unfortunately, and he is really 67-year-old and not 47. And now, if you're hemiarthroplasty over a total hip arthroplasty, you will reduce what? Early revision rate, dislocation rate, functional outcome, or length of stay. So hemi versus total, which do you reduce by choosing a hemi? So I'm going to stop sharing this thing. Are you seeing, I don't know, okay, please tell me if this poll is showing up on inopportune times.
Yeah, I don't see the poll.
Oh, no, I'm launch poll, all right. All right, go for it, 30 seconds. What are you reducing with a hemi over a total hip? All right, we got 70% engagement. That's pretty good. 30 seconds. Share results. Okay, so most of you think it's dislocation rate that gets reduced. Let's see what the answer is based on data. All right, so it's actually functional outcome. Dislocation rate is definitely in a lot of smaller studies and observational studies have shown that the dislocation rate is high in fractures, and this used to be our thought. Today we have a way of addressing dislocation rate by choosing different approach than the posterior approach, and also adding better implants. So dislocation, so recent randomized controlled trial, and the most recent one I'll talk to you about, but this one from 2011 was compared bipolar hemiarthroplasty to total hips and published in JBJS, actually found that in 4 years of follow-up, they had 120 years of follow-up. What they found was that the functional outcome is the one that was the only difference. They had the patients who were very functional or lucid had better function with the total hip. But this study that was just presented last week on the Orthopedic Trauma Association meeting, so it's hot off the press, hasn't been published in a journal yet, but I'm sure it's going to get published in a big journal. It's the health study, and they actually have 1,400 patients randomized to total hip versus hemis. It's 2 years follow-up. They have the average age is 80, and they're finding no difference between the two groups, except the total hips are trending to a little bit of a better functional outcome, and again in this more active population, but no difference in dislocation rates and what have you. So so that's it. Okay. So despite the slight advantage of a total hip replacement, you decide to do a hemiarthroplasty anyway. So you choose a press fit over a non-cemented stem to save time. So doing that, you now increase your patient's risk for what? Intraoperative fracture, dislocation, loosening, or a lifetime risk of periprosthetic fractures. And let me launch a poll for you. I think we are in, nope. Go. So what are we increasing with doing non-cemented? Right. Non-cemented hemis versus a cemented hemis. All right, we're getting to that 60%, 70% engagement. And we are gonna buy that. All right, so most of you think that it's intraoperative fractures that get increased with press fit stems. Let's see what the correct answer is. I'm sorry. It's actually lifetime risk of periprosthetic fractures, and that's very interesting. It's from another new study just from this year, JAMA again, and it was published by a nice surgeon from Hawaii by the name of Kanu Okike. And he is a Kaiser patient, and he looked at 13,000, Kaiser, sorry, surgeon, and he looked at 13,000 patients, age 60 or older, all of them got hemiarthroplasty in the 36 Kaiser Permanente hospitals. And it turns out that he didn't find any difference in intraoperative fractures. He didn't find difference in, although some of them arguably manifested after the surgery, so people did not report them during the surgery, or they didn't find them. Didn't find any dislocation or loosening. What he did find was this. This is actually a graph that I got by emailing him and asking him for his specific results, because I didn't believe them. But he talks about it in the paper, but doesn't show this graph. So you're probably the first people who are seeing this graph. This is so what you see. This is the risk of having a periprosthetic fractures up to 5 years after your hemiarthroplasty procedure. You can see that the risk of having the cumulative risk keeps on increasing and increasing, meaning anything that happened during the surgery, you would expect to manifest itself during the first month after the surgery. All of these fractures that are happening way like 3-4 years down the road are just for some reason related to the non-cemented implant, with no relation to what happened in the surgery itself. And obviously, this is a very well done study. They control for whatever you want and huge numbers. So this definitely should be taken seriously. All right. So in summary, young patients, they don't have this type of fracture. They have the transcervical fracture, not the mid-neck fractures, not the subcapital fractures. If they're non-displaced, you just put cannulated screws. If they're displaced, you put you should be doing probably a plate and sliding hip screw construct. And you should be choosing close reduction, because all you're doing with open reduction, if you can, or if it's not a successful close reduction, then obviously you need to open it. But if you can reduce it closed, all the advantage of opening it would give you is to get more non-union. So, and in all patients, you have this. These are the B1 fractures. If it's valgus impacted or non-displaced, you put cannulate screws. And if you have the basic cervicals are not really treated the same in the same algorithm, and if it's for the transcervical, you use a cemented hemi, or if your patient is high function, you should put a low risk. You can do a total hip replacement, but you have to address the dislocation rate somehow. So the modern total hip replacement, either with the implant or with the approach, you can reduce your dislocation rate so it doesn't become an issue.